minutes to go.
What is what?
Play.
I think there's. You just can say, welcome them. And tell them to let me do welcome.
You are right.
So welcome you all. The meeting will soon start. Bear with us in the next 3 to 5 minutes. My God's grace. Yeah. So we're starting by 2:08. These two. Where are you coming from? She's new this. When did she go?
She came from she went and went to this office. Okay.
Good afternoon, everyone. Can we start this meeting with an individual silent prayer? on behalf of Director of Pharmaceutical Service of University of Ilorin Teaching Hospital, Ilorin, Pharmacy Charles Iwakili, I welcome you all to this special edition of our clinical meeting. I recognize the fellow of PSN in our midst, fellow of West Africa College of Postgraduate College of Pharmacy, head of departments, head of technical and interest groups, pharmacists from diaspora, especially head of pharmacy, Oliver Hanna, distinguished pharmacy, we recognize you all. Today's topic is the use of digital technology to improve pharmaceutical care, documentation, and patient care. And our guest speaker is Dr. Chukuma Okoye, BPharm, PharmD, MCPharm. He was medical director of Epic Heights Pharmaceutical Limited between 2015 and 2019. Presently, he is a consulting pharmacy at CHFS Limited. He is a member of PSN Strategic Action Plan Committee 2021. He owns many certificates, including certificates in analysis, complexity, in myoclonal, single Australia in 2017.
Bishop blessing too much for now.
He is an ES consultant with many hospitals, including Anambra State and Oyo State Ministry of Health. He is a member of the Medical Laboratory Director, member ATPN, member PSN. Our presenter will use 50 to 60 minutes to give us his presentation, followed by questions and answers for the next 20 minutes after the presentation. During the presentation, please, every member should try and mute himself. And if you have any questions or recommendations, kindly do so by signify by raising up your hand, or you drop your comments in the chat box. At this point, I would like to invite our guest speaker to start his presentation. Dr. Chukuma Okoye, please, the floor is yours.
Okay, good afternoon, everyone. Can you hear me? Good afternoon, everyone. Can you hear me?
Yes, we can hear you.
Please permit me to off my video because the internet where I am right now is not too good, so that it will not affect my presentation. So,
okay, sir.
I'll be starting the presentation now.
Okay.
All right, so we are starting right now with the presentation of the day. And the topic, as the moderator rightly mentioned, is the use of digital technology to improve pharmaceutical care, documentation, and patient care. And in the course of this presentation, we're going to look at the above learning objective. We're going to understand the key concepts in digital technology and how it applies to healthcare delivery. We appreciate the concept of health information technology, which is an offshoot of digital technology. We will distinguish between electronic medical record and electronic health record. We'll also explore the benefits and applications of digital technology in pharmacy practice. And we examine the uniqueness of HealthServe electronic health record and the impact of health information technology in healthcare delivery. So we start by defining the word digital technology. It's a very common word these days. We have about digital technology in many discussions in today's world. So let's start with what is digital technology. Digital technology are actually tools, systems, devices, and resources that generate, store, and process data. And as you can see, going by this definition, that digital technology is actually a very broad term, which encompasses many of the technologies we use today in this modern world. Among them include the social media, the diagnostic equipment of all kinds, artificial intelligence, as we have in Google Maps that can direct you to where you're going without you knowing the place before now. Virtual reality, which we use today in communicating with each other, just like what we're doing now. That is part of virtual reality. And the Internet of Things. And when we talk about Internet of Things, we are actually referring to a situation where two or more electronic devices can communicate to each other at distance through the use of internet. For instance, if we have a blood pressure monitor that can read a patient's blood pressure and send that information through an internet to another device located somewhere, that is what we call Internet of Things. But we're going to narrow our discussion today to health information technology. And it's actually a part of digital technology because digital technology is actually very vast. But health information technology is just an offshoot of digital technology. So let's go ahead and understand what really is health information technology and whether our practice is actually part of the definition of health information technology. So let's look at that in the next slide. So, introduction. Health information technology is the application of information technology in healthcare delivery. So whenever we apply information technology of any kind in the delivery of care, we are actually using what is referred to as health information technology. So by way of definition, this involves health information management across computerized systems and secured exchange of health information between patients, healthcare professionals, healthcare providers, health maintenance organizations, and health regulatory authorities. There are two approaches to digitalization of healthcare delivery in health institutions. I know we must have been hearing about electronic medical record and electronic health record. They are very common terms when we talk about healthcare digitalization. So, but we need to ask ourselves, when we're implementing health information technology, what type of health information technology are we implementing? So today, by the time we finish with this discussion, we're going to evaluate any health information technology system in healthcare delivery and classify it as either electronic medical record or electronic health record. So electronic medical record is health information technology system that is used to manage patient clinical information within one institution. Electronic medical record has been with us for some time now, but in today's age, there is now an evolution of electronic health record, which is a health information technology system that is used to manage patient clinical information across multiple institutions and provide a more holistic, long-term view of the patient health. And the closest way or analogy to explain these two concepts is if we have a situation where we have an ATM card that we can only use within our bank, that can be referred to as electronic medical record. But if we have an ATM card as we have today, where you can use the same ATM card in various ATM machines from other banks, that we can refer to as electronic medical health record. So, health service system is designed to be a cloud-based healthcare delivery management platform that enables healthcare professionals to deliver superior clinical services to their patients by leveraging on unparalleled patient data management. Another concept we need to look at is the telehealth. Telehealth is another very common concept we talk about today. And another one is telemedicine. But in the course of this discussion, we need to look at is telemedicine actually the same with telehealth? So by way of definition, telehealth is the provision of healthcare services remotely by... Can you hear me? Telehealth is the provision of healthcare services remotely by means of electronic information and telecommunication technologies. In contrast, telemedicine is the practice of medicine that uses electronic information and telecommunication technology to deliver care at distance, and it specifically covers clinical services as against other range of services that are obtainable when you talk about healthcare delivery. So as we continue, telehealth refers to a broader scope of remote healthcare services than telemedicine. Telehealth encompasses patient and professional education, public health services, health administration, in addition to a wide range of clinical services, such as immunization, family planning, and all the rest of them. Lastly, telepharmacy is the delivery of pharmaceutical care remotely by means of electronic information and telecommunication system. Also, as we talk about telepharmacy, there's another concept we talk about, we call online pharmacy. And we know that lately, PCN has come up with a guideline for the practice of online pharmacy. But online pharmacy, is it exactly the same thing as telepharmacy? And the answer is no. Online pharmacy is basically the type of pharmacy where you can have the drugs displayed online, and you can pick whatever you want to buy from that pharmacy using their online pharmacy platform to buy your drugs, and that is basically what is online pharmacy. But when we talk about telepharmacy, it's the use of the delivery of pharmaceutical care services as we know it by means of electronic and telecommunication technology. And that is one area that we need to improve on, because we talk about pharmaceutical care services, we need to document whatever that is any intervention we are making for the patient using whether paper or electronic based system, as we're talking about today. So why do we need digital health information technology in pharmacy practice? Of what use is digital health information system to pharmacy practice? Now, digital pharmaceutical care documentation tool can easily adapt to varying documentation needs of community and hospital pharmacy practice, as we are going to see when we get to the practical section. Also, it presents great opportunity for interprofessional and intraprofessional collaboration in patient management and continuity of care. And it's also a good source of data to conduct clinical research in pharmacy practice, both individually and collectively. It equally has an intuitive and adaptive documentation tool to enhance the productivity, efficiency, and ability of clinical pharmacists to identify lapses in drug therapy management. It brings the prospect of integration of pharmacist-initiated clinical documentation into the mainstream patient folder system. So what we are actually saying is that as we continue to improve on our patient documentation, it's very important that such documentation does not just end up in pharmacy department. There is need for such information to be integrated into the patient folder, such that other clinicians can leverage on such information to make an informed patient care when it comes to drug therapy management. It gives a wider geographical coverage and increased visibility and higher clientele base. Based on what we have discussed so far, that apart from having the brick and wall kind of pharmacy, we can actually have our pharmacy provide services using the telepharmacy and even online pharmacy. That will give us an opportunity to actually increase our clientele base and even increase our revenue generation. Creation of value-added services that will increase revenue in pharmacy practice. Today, for those of us in community pharmacy practice, much of our revenue comes from drug dispensing. But on a good day, we ask ourselves, the knowledge that took us 6 years or more to acquire in pharmacy school, how do we monetize that knowledge? That is the question that I want every one of us to ask ourselves. Are we really making money from our knowledge, just as our colleagues who are physicians, dentists, or optometrists can make money from their knowledge? Instead, the pharmacy practice we have today basically make money by selling physical products. But if we leverage on technology and offer more services that will improve drug therapy management, because we know that fine, drug is meant to help to prolong life and to save life. But we all know that drug is equally harmful when it's not used rationally. And the public needs the expertise of pharmacists for them to make rational use of drug. And we ask, how well are we living up to that responsibility? That is the value we're talking about here. With digital technology, we can do better than we are doing at the moment. And there's higher clientele satisfaction and customer retention. Going by what we have been saying since we started this presentation, you will agree with me that with digital technology in pharmacy practice, pharmacists will have a better chance to satisfy their patients' health care need. And of course, that will lead to customer retention. Also, there will be business intelligence to guide better allocation of scarce resources. There will be that we're also going to raise the standard of practice and data that will help pharmacists to better convince the government that drug dispensing is not for untrained drug retailers. Transparent and efficient management of fee-for-service drug billing in community pharmacy for robust health insurance management. Now, like we said earlier, that what we are offering Nigerians and other developing nations is electronic health record. So let's look at some of the features that we have on that system. It has seamless continuity of patient care across professional and institutional boundary. There is a robust biometric-enabled patient identification system and folder retrieval for easy management of patient clinical files. There is clinical clerking tool. There is digital pharmaceutical care tool. There's e-prescribing tool, meaning that you can actually prescribe drug digitally instead of using pen and paper to do that. There's also a referral tool when that is necessary. There's a requisition tool for you to send patients to lab for laboratory investigation, X-ray, ultrasound, CT scan, EMR. Collaborative patient care, of course, as we are saying, with this electronic health record, it becomes much easier for clinicians who are managing a patient to collaborate to improve the treatment outcome. There's also patient follow-up tool, meaning that clinicians can actually engage with their patient in real time, regardless of the current location of their patient, because the system has an AM-built communication tool, just like we have in WhatsApp. Also, there's billing tool for you to manage your billing on the system. There's tool for clinical decision-making, public health policy, and detection of public health emergency and disease outbreak. And so there's health insurance management system for end-to-end interoperability in healthcare delivery under health insurance system. And there's clinical governance for the clinical governance and internal health system audit. Now, as we know, every technology will evolve over time. At the moment, we still have quite a number of tools that are still under development. Among them include the e-labeling of medication and drug dosing reminder for patients. What we're actually saying is that with this technology, in the next coming few months, we can actually use a digital system to label medication and have it printed out, and you stick it on the product that you are dispensing. And beyond that, talking about drug dosing reminder, with this system, you can actually set the timing of taking each drug by the patient. And when you do this, the system will help you to track the patient drug adherence remotely without you being physically present with the patient all the time. There's also telehealth consulting with video call and audio call option embedded with clinical documentation tools. There's automated drug interaction checker and contraindication checker as well. Also, artificial intelligence and machine learning. Artificial intelligence and machine learning to monitor medication and medical error is also part of what we are working on at the moment. Lifestyle management for the patient. This is talking about the fact that what makes one to be ill or to be unhealthy also comes from our lifestyle. For instance, our body mass index, our substance abuse, and dieting, and all of that contribute in one way or the other in many ailments like diabetes, obesity, high cholesterol, and so many other ailments that have something to do with our lifestyle. And so the system is going to support clinicians in delivering individualized information and instruction that will help patients to improve their quality of life using artificial intelligence. Internet of Things for remote objective patient monitoring. Product inventory and full accounting solution. Business intelligence. AI-powered disease factor index calculation system. So now, how do we use HealthServe EHR? So you can use HealthServe in both hospital and community pharmacies, as well as medical laboratory and health insurance companies. You start by opening an account for your HealthServe, for your institution on HealthServe registration page, as we have done for University of Ilorin Teaching Hospital. Also, you get all staff to create their professional account according to their role in healthcare delivery, and enroll them into your hospital or pharmacy account on HealthServe, and give some privileged access to perform certain specific functions within your institution. You get your staff to create e-folder for patients and clients in your institution, and enroll the patient according to their various health insurance or private policies. Attend to patients using HealthServe platform and document all your intervention in the patient e-folder in real time. HealthServe account comes with also a referral link that you can use to tell others about HealthServe and earn commission when the invitee activate their institutional account on HealthServe. So in conclusion, wide-scale adoption of digital technology in pharmacy practice, with particular emphasis on health information technology, holds enormous potential for the advancement of pharmacy practice, relevance and survival of pharmacy profession in 21st century, change in the public perception of pharmacy practice, and government recognition of the pivotal role of pharmacists in primary healthcare delivery. Therefore, there is urgent need for pharmacists to align with digital technological innovation designed to bring their professional expertise in drug therapy management to limelight. Otherwise, those in position of authority in health sector will foist a digital system that will suppress the clinical expertise of pharmacists in drug therapy management. This unpopular trend is already gaining ground, as some of the few health information systems in government hospitals today only have tools for inventory management for hospital pharmacy department. This is in sharp contrast to an ideal health information technology system for optimized healthcare delivery in Nigeria. And these are some of the references we use. And at this point, we need to now proceed for us to have a practical feel of what this system looks like before we go to question and answer. But I'll be very brief on that particular section, just for us to have a glimpse of how this system works. I will take you through from the point of logging into the system. Okay, so this is my login. I'm about to log into my pharmacist account so I can work with this solution. I hope you can see my screen. So I'm logging in.
Yes, you can see it. Yes. Go on, please.
So, like we mentioned during the presentation, that this system works with a biometric to retrieve patient folder. So we're going to see that shortly. But before I do that, I have to show you how to add a new patient into this system. So as a pharmacist, when a patient comes around and it doesn't have e-folder yet, if you're using this system in your hospital, you click on add patient and you fill this form. Once you fill this form with the patient detail and you click on add patient button, instantly, if every information is right, the system will give you a unique user ID for that patient folder, which you can use to attend to that patient. So having described this on how to onboard a patient on this system, let's go ahead and attend to patient. So I'm going to attend to patient using myself But at this point, you can see that we have various options you can use to retrieve a patient folder. As against what we have today, where a patient has to provide their patient card and they will go to medical record to look for the patient file. We're saying that approach is already outdated and obsolete. So what we propose is for you to retrieve a patient folder using a biometric, and let's go ahead and do that. So with this technology, once you have profiled the patient biometric for healthcare delivery, just like the way papers are profiled for NIM registration, BVN registration. When you profile a patient, all you need to do is to click on collect fingerprint, and you ask them to put their thumb on that device, which I have right here with me. And I've captured my fingerprint template. This fingerprint template will be used to identify me because, as we know, fingerprint template is one of those biometric data of every individual and is unique to everybody. No two individuals in this world share the same biometric. So if I have captured this, I can now identify this patient by clicking on verify fingerprint. And the system will identify who has the fingerprint. As you can see, that process has been completed and it has identified me as the owner of this folder that is attached to this fingerprint displayed above. So having identified the patient correctly, you now click on get patient folder and the folder will open up now. So, and that's the patient folder. So, and these are information that are already in this patient folder from different healthcare professionals, from physicians, nurses, doctors, and all of that. So now, how do we document patient care in this system as pharmacists? The process is simple. You just click create new record. Whenever you want to create a new record or document in patient folder, you click create new record. So if you want to document pharmaceutical care, you click on pharmaceutical care and the system will load pharmaceutical care tool for you. So if I click on this, you can see various sections we can use to document pharmaceutical care. But it does not mean that every time we want to manage a patient that we must use all these tools. It depends on how the interaction with the patient proceeds. So let's start by looking at what we can actually capture with subjective data. So I've selected subjective data. Now let's see, under subjective data, we can capture patient complaint. Whatever is the complaint of the patient, we can actually put it here. We can also capture the history of present illness using that section. So what this means is that it must not use all the tools all at the same time. You only make use of the tools that you have need for at that point in time. So we can add more tools, as many as we want to. You can add family planning, history of the patient. You can add immunization. You can add even allergy. So this will help us to actually carry out comprehensive patient documentation in a flexible manner. All this while we've been talking about subjective data. How about objective data? Let's look at that as well. So we can actually capture objective data. As you can see, we can take blood pressure, for instance, can take pressure of 120/80. And for each of them, we always have to give reference so that there will be value to now compare whether the result of that patient is what it ought to be. Then we also have to take the pulse rate. If you measure the pulse rate, you have to add the pulse rate, which let's say is 75. Let me add all of them, 18 for the respiratory rate. Temperature, let me say is 37. Blood oxygen saturation, 100%. Height, 1.8. Weight, 75. Pain, no pain. So I can now go, if I like, I can say this way. But if I want to be thorough in my documentation, I would like to add reference so that I will have comprehensive database when I save this. And remember that unlike when you document for a patient and the folder just only reside in the hospital, this system actually allows patients access to view their folder and interact with it from their own patient end. So now I'm putting references, what should be normal or abnormal as the case may be for this patient. So I got this reference is saying what will be an ideal weight for every individual's height. So for someone that the height is 1.8, which is 180 cm, the person should weigh between 65 to 81 kg. So for the pain, no pain, meaning that the scale is 0. Then we can even document the laboratory investigation. For instance, if I want to document fasting blood sugar, I can do that. And then let's say I did LDL, can add that, and this HDL, all right? So I can enter all the values I got from this test. Let's say 75 milligram per DL. LDL, say 120 milligram per DL. Then HDL, 60 milligram per DL. So if I have my references, I can add what is the references here. Now, there's another important thing we need to look at in this tool, which is the monitoring parameter. How do we use this tool? We use monitoring parameter to establish our treatment goal. For instance, if under objective data, and I state the fasting blood sugar, which is, fasting blood sugar, and at the moment, the patient fasting blood sugar is reading 150 milligram per DL. And I want to have a target of 115 milligram per DL. What this system does is that it's going to save this data somewhere so that in subsequent visits by this patient, you can actually monitor the patient progress to the treatment. And that information goes to this location, which is pharmacotherapy. You see, we have monitoring parameter. You establish your monitoring parameter here. After saving this document, this monitoring parameter will migrate to pharmacotherapy, monitoring, and evaluation, so that whenever the patient comes back, you can simply write the current value of this, and you can now compare whether you are coming close to the target endpoint of the treatment you're administering. And as you're doing it for the objective data, you can equally do the same for the subjective data. For instance, if someone is taking antidiabetic and it says that you urinate 5 times before they break, and you want to monitor that frequency of urination at night, you can set the target endpoint for that. Maybe say urinating once or twice before they break, and you now follow up for each visit whether the frequency of urination is coming down as the patient is taking the medication. So once you are done with all of this, you click Save Documentation. And when you save this documentation, you can always review what you have done for each of your patients that you have documented in their folder. So, and the patient I worked in the folder is my own personal folder. So let's open it and see what is there. And in this case, you don't need to scan the patient thumbprint for you to see this information. So anytime you want, you can always review your documentation and what is in your patient's folder. Can you see what we have just done now? How comprehensive the file is. These are all we have documented. We didn't really document much, but you can see how robust our documentation is on this patient folder. So with this, we can actually follow up on our patient treatment on a continuous basis and set up a monitoring parameter as we administer treatment to the patient. And that will help us to also make informed judgment on the best treatment approach. Also on this system, we have patient follow-up, meaning that you can actually contact your patient in real time and exchange communication with them. And that is the tool for that, patient follow-up. So it has a live chat system that can use to actually chat your patient up in real time. And they can respond to you as well. And by next year, we're going to have the mobile app for this system so that the communication with the patient can be done in real time. It's not only when they're on the web, on the browser, that you can read them. By the time we release the mobile app, they can engage with your patient better. There are more to this too, but basically with what we have done so far, you will now have an idea where we're heading to and how this can impact our practice when it's properly implemented. Thank you for listening.
Thank you, sir. Thank you, sir. This is very impressive, educative, and inspiring. A lot of us have not come across telehealth. Now we are talking of telepharmacy. Thank you, sir, for this comprehensive presentation, sir. So, sir, we start time for questions and contributions. Please kindly signify by raising up your hand if you have any questions, or rather you can see drop it in the chat box. So we have like 10 minutes to 20 minutes for that session. So the floor is open. Okay. We have Dr. Abdurrahim Malik from USA. Sir, can you unmute yourself and ask your question?
Can you hear me?
Yes, we can hear you.
Okay, thank you very much for the opportunity. And thank you for Dr. Jude Okoye for the inciting and exciting presentation you gave. I have two questions. The first one is, maybe I missed some parts of it, but my question is, now that UITH is registered, if I'm a pharmacist, let's say I'm in Maiduguri, am I going to have access to UITH patients in Kwara if I can log in into the system? That's my question number one. Basically, how do you protect the privacy of the patient in the database from every pharmacy nationwide? Some, of course, shouldn't have access to it. Then the second question is the way the application, or I should call it the software, is what, considering the limitation pharmacists have in diagnosis and prescribing, how does this conflict with the law? I know we all prescribe all the time, but how does it conflict with the law that we recognize we as dispensers? Of course, we prescribe unethical drugs by law. We're allowed to prescribe OTCs and all that. How does this conflict with that? If you can just enlighten me a little bit on that. Thank you.
The second question, can you elaborate more on what you mean by that?
Okay, on the second question, for instance, now, we as pharmacists, by law, we are not allowed to prescribe ethical drugs. Like now, somebody walks into your pharmacy, you are dispensing amlodipine or you are giving them insulin and all that. These are roles for doctors. But from this software, I can see where we have the opportunity to actually prescribe ethical drugs, and how do we control prescribing controlled substances on this platform? Is my question clear now?
Yes. Well, I will start with the first question you asked about patient data privacy. In every institution on this system, the institution have the free will to decide how patient data will be shared, even within their own institution. So for that reason, for instance, this one can decide that those in the account and even medical record should not have access to patient folder. So if they set their own institutional application to work that way, that means that even within that institution, those from this kind of supporting staff will not have access to patient folder. And even core professionals can be regulated. They can decide who among the core healthcare professionals to have access to patient folder. And of course, if they everybody have to set if they want their patient information to be seen outside their hospital or their pharmacy. So they're setting for all of this in that application, but that is on the institutional interface, because I haven't shown you the institutional interface. That one is different from what we have seen now. What we have just used so far is the professional interface. Is in that institutional interface, you can do all this type of setting that regulate how a patient data can be accessed.
Okay.
But then, for instance, if a patient is prescribed a drug in a teaching hospital and they don't have the drug in the pharmacy department, and the patient choose to go and fill that prescription outside, that is different. When he goes there, he can actually fill it outside, but if the hospital has actually set their system that they can't share the data outside, prescription is more like a communication to a pharmacist, and anyone who gets that prescription can fill it, and once he fills that prescription from any pharmacy that the patient visits, it disappears from the system. Then on the area of collaboration, or rather the pharmacist prescribing drug and at the same time dispensing. You see, with collaboration, as we are doing at the moment, we're actually engaging with National Association of Nigeria, Private Medical Practitioners of Nigeria, which is the former AGPMP, now ANPMP, that's their new name, as well as the Medical Laboratory, Guild of Medical Laboratory Directors, which are the owners of medical laboratories across Nigeria, and of course our own ACPN. With this, there's going to be a collaboration so that the hospital can prescribe a drug and a pharmacist in community pharmacy can dispense the drug for the patient, because it's going to be an ecosystem interconnectivity. Like I said during the presentation, that at the moment, what the future of healthcare lies in electronic health record, which is a more like an ecosystem healthcare delivery that will be interconnected, all the stakeholders. That is what we're looking at to improve healthcare delivery.
Okay. Thank you very much.
Thank you. Next, there are any contribution or questions? Please signify by raising the hand if you have questions or contribution. We have a question in the chat box.
There is a question here by pharmacist Mrs. Elegbede. She said the patient can have access to their interact with their folders. I want to know if by interacting, they can make inputs of any form of data into their folders.
Yeah, I can hear you. Yes, the patient cannot.
You said that
yes.
patient can have access to interact
Yes.
with their folders. I want to know if by interacting, they can make input of any form of data into the folder.
Patient cannot make, yes. Patient cannot actually add any information on their folder in the system. They basically get to know what is in their folder, and of course, sometimes what is the folder can tell the patient what to do, how to take a medication, what lifestyle modification they need to observe for them to achieve the treatment goal. So these are the information they are going to see in their folder, but they cannot change anything. However, there is actually an ongoing interest in what is referred to as digital health. And digital health is actually a kind of a system where the patient can actually get more actively involved in their treatment by way of trying to put in some information from their own end. For instance, they can try to ask them their diet, their lifestyle, and even their nutrition. And it's going to use such information that it obtains from the patient to have a more complete knowledge of the patient, so that such information can be used by artificial intelligence machine to advise the patient on how to improve their quality of life. If, for instance, one takes a lot of calorie, such system can understand that this patient actually consumes a lot of calorie, or that this patient doesn't exercise enough, and it will tell the patient what he needs to do for him to achieve ideal body weight, and so much more. So, and currently there's a project, a grant that is coming from Net Foundation in US, and even another one that is coming from Bill and Melinda Gates, targeting how they can improve maternal mortality rate in some African country using digital health. They want to have a situation where pregnant women can modify or get actively involved in their antenatal care by using digital health, so that such solution can support intervention from clinicians to improve the outcome of maternal care in the emerging economies.
Thank you, sir. Any other contributions or questions? Sir, Pharmacist Anna Oliver.
Thank you. Thank you very much, Dr. Okoye.
Thank you, sir.
Yeah, I want to get a point clear. Is this going, when you say the patient is going to input, so as you are inputting, the patient is also doing the same thing? How about a patient that is illiterate and cannot do all these things you just mentioned? That's part A of the first question I want to ask. This other one is, I'm trying to see how we can marry these two systems together. You are inputting, the patient is also doing that. I know there are in the US here, there are laws for HIPAA and all those things. We don't have them in Nigeria, but it's also understandable that if you're trying to have something like an MTN, the monitoring aspect of it, and you want your patient to input information into this system, how do you think this is going to work out? Because I know the only even when you are dispensing a controlled substance in the US, you have what you call the e-force, whereby you can check everything about the patient taking drugs which are controlled substances, which the patient doesn't really know. In short, I'm trying to figure out how this thing will work out. Is this only going to be limited to institutional pharmacy and not to retail pharmacy? And when another pharmacist asked the first question about prescribing, well, we're allowed to prescribe certain medication, like you said, non-ethical, and then you can even go further. But I'm still not waking up enough to know if it will make sense for the patient to enter information by themselves. I'm a little bit confused. So I want you to explain that a little bit so that I can see the benefits of this interactive session. Thank you.
All right, sir. So the type of information that parents are going to put inside the system is actually a different type of information. Like, let's say, for instance, they can impute their blood pressure reading if someone is hypertensive. They can even check their blood sugar reading at home using glucometer and impute such information from the patient end. The database is different from the clinical information from healthcare providers. But when the system wants to use artificial intelligence to understand this patient better, because it may go to hospital once or twice in a month or even in a year. But your healthcare is a continuous process. So by the time the system gets the daily information coming from the patient, and then it now merges it with the clinical information, which is a different type of tool and system, you put it together, it will understand better the patient health situation and need to deliver individualized intervention to help the patient better manage their health. But the information, the type of information being imputed inside the system, they are entirely different, and it's not like the professional interface we have seen. But even this patient input system hasn't been fully completed on our own side. It's because our organization equally applied for the MEF for Mother intervention, which is targeting Nigeria, Kenya, and India. So under that intervention, they want a digital health that can help to improve maternal care management in these three countries I've mentioned. And that is why we are equally trying to build up such a system. But the information patients are going to put is different from the one that the clinicians will put in the system. They're talking about how will someone who is not literate do this. This patient input system is not only going to be typed into the system, it's going to have a voice input system that the system can ask you questions orally and you respond. And it cannot put the information in the system without you, the patient necessarily having to learn how to type anything for you to interact with the system. Yes, sir.
That makes sense. Thank you very much. I think if a patient can talk and then you can get information, even in the US, you have a lot of them who cannot even, they don't even know the medication they are taking. And then you are asking them to start imputing, they will have difficulty. But I think the voice catching aspect will really pay off, because you ask an illiterate, even literate, even we who are pharmacists. I can remember many years ago, in the pharmacy school, they said a prescription was brought into the pharmacy. It says use as directed. That's why we decided to stop there. Use as directed, and it was a suppository, and it looks very fine, strawberry-like, tiny, a suppository. And the patient brought it, you look at the said you use as directed. And then when you type in the thing, you use as directed. The man looks at it and says, oh, wow, God, this is beautiful. This is so nice. Instead of inserting in the anus, decide to swallow it. So you see the mistake, the pharmacy would have been able to either communicate with the prescribing doctor so that the confusion does not come, Well, there's a way were able to solve that, no longer as directed, you have to put the direction there. So this is a good system. I love it. I love it very much, especially the one that you said, okay, the patient can talk. Even I myself, if, the portal we use when they say enter, I say, I'm referring to me as a patient now. I'm seeing my neurologist and all the inputs you put there. Sometimes I find it difficult to enter the whole thing. Even with all, exposure, I still find it difficult. So, I really like what I'm hearing from you, and it's going to stimulate me in my practice. And I will try to see if I can get some of my colleagues here to share it with, because we have them here, but not as much as, because everybody here is so busy to get something out. But if it's in the institution, yes, but not in the pharmacy outside, the retail pharmacy. I don't see how the retail pharmacies will be able to go through all these things. Thank you.
Welcome, sir.
Thank you, sir.
Thank you.
Thank you,
Welcome.
And thank you, everyone. But before we close, I would like to recognize these important people. First, pharmacist, Dr. Oliver Hanna, Dr. Abdurrahim Malik, pharmacist Christopher Kuku, pharmacist Bakau Ali, pharmacist Nora Abdullahi, pharmacist Ilya Buba, Dr. Jesus Ukadike, Mrs. Margaret Ogono, and every other participant in this special edition of legal meeting. We appreciate you and recognize everyone. Thank you. So over to you, Dr. Bello.
Please say hi to Dr. Bello there, because I can see that it's not on mute, it's muted. But I want to say hi to you. It's been a long time. I haven't heard from you for a while. So it's nice seeing you and maybe hearing your voice.
Thank you for gracing our meeting. We are honored,
yes.
Sir.
Yeah, I have to ask my wife to wake me up. So by 7 or 7 a.m., say, look, you say you have something to discuss.
Our guest speaker, Dr. Jude, it's nice having you around. We are honored.
Okay.
Yeah, I'm grateful.
Thank you very much. I want you guys to keep it up.
I want to call it the end of the meeting.
Thank you.
Yeah, thank you so much, sir. So, Dr. Jude, we're grateful for sharing your water knowledge with us in indicator technology. It is recorded and to be shared with all the participants by God's grace.
Dr. Koye, can you give me your number?
For your comment.
Can you give me your number?
For now.
Okay, thank you.
Any comment?
All right, I will type it on this.
Okay, thank you. I appreciate it.
Sir?
No, I'll say I appreciate. I have Dr. Bello's home.
Okay.
So, but okay, thank you very much. I've seen it.
Better, yes.
083. Thank you very much.
All right, sir.
Bye-bye. Okay, thank you. Let me see if I can go back to sleep again. Okay, thank you.
All right, sir.
All right, bye-bye.
Dr. Duke, number is 9.
Okay, it's bye for now. Thank you all.
Bye.